This episode of Cheat Codes, a Sickle Cell podcast, is intended for informational and entertainment purposes only. This episode of Cheat Codes was supported by Adaqvio.
What's up, Cheat Codes listeners? It's me, Dr. Z.
And me, Dr. C.
Dr. C, this episode that, once again, we weren't able to actually do the interview, but get a chance to actually look forward to listening to an interview fresh, has a guest that I'm thrilled about. And I'm going to tell you why. I think you know why, Dr. C. It's because, the guest on this episode is more than just a sickle cell colleague. Yeah, he's a friend.
For sure. And a great guy who's really done so much in sickle cell research in a relatively short time. He does a lot of stuff with technology, but has a great example of what you can do with a transition program. And so happy to have him on. And I'm excited to hear what he has to say about transition, because it's such a big problem. We've had so many challenges around transition. I know in Detroit, as the director of the sickle cell program, for a while we stopped transitioning patients because people would fall through the cracks and have bad outcomes, and we really just couldn't let that happen. And we tried multiple iterations of how to transition best. And I think it's just a hard thing for everybody to move from childhood to adulthood and take over their own care, and especially if you have a chronic disease like sickle cell. And so, we need people figuring out the best practices for that, figure out the best way to really get people prepared to be their own caretaker.
So we've got Dr. Nirmish Shah, the director of the transition program at Duke University, who will be joining Patrick James Lynch as they talk through Dr. Shah's career, his transition program, and some other things. I'm looking forward to this interview. I hope you guys enjoy it too.
All right, joining me now for today's interview from Duke University's School of Medicine, Dr. Nirmish Shah. Good afternoon to you, Doctor. How are you today?
I'm doing very well. Thank you so much for having me here today.
Appreciate you being here. Thank you for coming on to Cheat Codes. And let's dive right into it. I understand that there are a few main areas of research that you focus on, including the transition from pediatric to adult care for sickle cell disease. Can you provide me with an overview? Historically speaking, why is this transitioning topic an important one? And what are the major challenges in helping a patient successfully transition from pediatric to adult care in sickle cell disease?
Yeah, I think it's a great question, and I really do appreciate you taking the time to focus on transition. This has really been something that I've been working on for quite a while. I think that the issue comes up with any chronic disease. That a patient that's born with a situation where their life is going to go through a journey where there's going to be ups and downs and a lot of different complications that might come about. And so in sickle cell disease, when you have a disease that just is progressive, you have unpredictable complications such as pain, you want to prepare that patient and family as they move through life. And one of those big moves is moving from pediatrics to adult care. And really, I think the big thing that I often try to get patients and families to understand is that it's a process. It takes time. And so it's not like we can just label a patient as saying, well, you're 18, and so now you're going to move on to the adult world, and magically something changes when they become 18. It really is a long process, and so because of that, there are a lot of nuances and a lot of things that we have to consider as patients become an adult.
What has your research into transitioning from pediatric to adult care taught you about how we can improve the process for patients and caregivers?
Yeah, I think we're learning more and more, and one of them to consider in the research is that really and I know this is often just said for a lot of different things, but it takes a village. It really takes a lot of people to try and surround a patient and their family and their caregivers with the resources, knowledge, education, and the logistics to get them, quote unquote, successfully from pediatrics to adults. And so I'll give a couple examples. The first is, when I say it takes a village, the more people you can have that are seen in both pediatrics and adults, there is some evidence that leads to more success. And so I lean on a little bit of that evidence coming out of St. Jude's. But I'm one common face, and that's great that I take care of patients on the pediatric side. I take care of patients on the adult side. So I'm actually really lucky that I can literally walk my patient to the adult clinic. But that doesn't happen in many areas. But even though I'm a familiar face, I know that patients want a lot of comfort and trust that really is built over years. And so to do that, we now introduce the adult teams early in the pediatric process of transition. We try to have the pediatric teams continue to make contact once they become an adult. So there's this kind of connection between the two sides, which I think is pretty critical in trying to surround the patient with some familiarity, which then again leads to trust. And the only other, I guess the other example I would give of some of the research that we're looking into is the more connection you have, the better you do. When I say connection, we're part of one study that's ongoing and led by Dr. Asunko over in Charlotte. But does peer mentoring, does someone else reaching out and touching a patient help? And I think that there's a lot of models in other diseases that show that this is potentially very helpful. And I think sickle cell is, again, another group of patients that we really need to give extra attention to. And that's where peer mentoring, having a sickle cell educator that engages with the patient, not just on a medical side, but also on a social side, all those things I think are very helpful.
Well, that kind of dovetails nicely into the next question that I have, which is kind of focusing on the patients and the caregivers. Is there anything that they can be doing differently or thinking about differently to have the greatest chance at successfully transitioning care?
Yeah. And I hope we get into this at some point too, but I'd love to try and define what success is, right? So that successful
Sure.
getting into adulthood is a relative term. It can vary, but I'll start by answering by saying that one thing that needs to be done is to, again, remember it's a process. It's not that I think sometimes the word transition and transfer get kind of mislabeled. I have a lot of residents or fellows or even students or nurses that say, oh, this patient is, it's already transitioned, but really they've transferred. Transfer is the handing of the baton off from pediatrics to adult. But transition is this whole, whole process starting at age 12 to 13. Usually the guidelines say start as early as 12 to 13 years of age. And the patients and caregivers and families need to focus on the fact that we need to get this patient and of course, everyone around them ready to be as independent and successful in caring for themselves when they become an adult. And part of that is, and again, this is me wearing both hats, pediatric and adult. On the pediatric side, we often say, and this is not a knock to the adult side, but on the pediatric side, there's a lot of love. There's a lot of hand-holding. That, if you miss an appointment, we're on you to say, why are you missing this appointment? On the adult side, you're an adult. And many times, we try to give that extra call to say, why did you not come? But many times with what I've seen in other hospital systems, that there's just not as many resources on the adult side, and we regard the patient as an adult. And again, with cognitive issues, with issues with patients not really being as well prepared as we'd hope them to be, that can be an issue. And so I think patients and families and caregivers should all try and focus on how can I get this patient to be as independent and knowledgeable and educated about their disease. And so that's a lot of what I do on the pediatric side.
What then defines success? Is it the ability to have all of those tools in your toolbox during this transitional period? To your point of emphasis, this is not like it's morning time and by afternoon. This is a multi-year, many-person process. What does define success?
Yeah, no, and this is actually a moving target, and in a good way. It used to be that success, and there were actually papers out there that said that success was graded as just making it to their first appointment on the adult side. Then we had modification of that success as, okay, well, making it to the first appointment and being in the adult clinic for at least 2 years. And then we modified it and said, okay, well, not only they get to the adult clinic and they're there for 2 years, but they also understand their disease. And there's a transition readiness assessment questionnaire that's now been developed by the American Society of Hematology. There's a track questionnaire. So I think more and more we're pushing to say we should not just settle for, you have an adult provider listed, so we're going to call that good. We're going to say we really are going to set a high bar and expectation. And that then trickles down to say, well, if this is the expectation for quote unquote success on the adult side, I have to get that patient ready to be able to be, classified as success on the adult side. And the way to do that is to start early, to provide all these resources and education, et cetera. So I do think it's a moving target, and I think it's definitely in a good way.
In your opinion and experience, and based on your research, do sickle cell disease patients face challenges in transition that are unique to sickle cell disease and not experienced by patients managing either other rare or chronic diseases? And if so, what are those unique challenges?
Yeah, I absolutely think that the sickle cell population it has a hurdle that many other chronic diseases don't have. And I know this from experience and talking to colleagues that are in other chronic diseases. And we've worked as a group at Duke to have a lot of collaboration between transition efforts in other diseases such as congestive, the heart disease, congestive heart failure, and heart disease and transplant, in GI-related, rheumatologic-related transition. And what we see, and it seems to be unique to a certain extent, is there's not enough adult hematologists. There's just not enough emphasis on the adult side. And so I think that we have all this discussion about how we want patients to be successfully transitioned and transferred to the adult side. But if you don't have someone to catch them, you're in this unique situation where you've done all this work to get them to be as successful as possible, and then you don't have someone to hand that baton off to. And so that is something that we're working on. And I think that in that mindset, we're trying to get a lot more interest by primary care providers, by hematologists, oncologists that usually do more oncology. We're trying to get centers to try and focus money and resources for those hematologists that are there are few and few between, aren't too many around the country, but are overworked to a certain extent because they have so many patients they need to care for, but they just don't have the resources. So I think it's an evolution. I do think that that's been improved a little bit over the last 5 to 10 years, but I do think for sure that is a unique aspect that we as sickle cell providers within hematology have that other chronic diseases, from what I've seen, don't have.
Thinking about the existing hematologists and sickle cell disease specialists and experts that do exist, can you share a little bit with our audience what kind of network exists amongst providers? There's two things that kind of come to mind for me, both that transition from pediatric care to adult care, and how much on the provider side is there conversation and the ability to refer back to a previous provider. And then also for an adult who, say, gets a job in a different state, has to move states, needs to find a new center, what kind of communication is happening on the back end between care providers?
So I'll start with the first aspect is the communication between the pediatric group and the adult. And realistically, it doesn't happen enough. and I really think the emphasis should be that it should happen more. We need to have a good strategy to try and help that. It is, of course, the expectation to try and have the pediatric folks collaborate with the adult group and have these conversations. And to the point that, the American Society of Hematology put together a consensus and put together forms that should help that process happen. So, I mean, the understanding is, yes, it should happen. Does it happen consistently? And does it happen to the extent it should? It really doesn't. And I think it goes back to the previous point. There's just not enough hematologists to say in every area, in every major area, do I have a go-to adult person? And if I do have a go-to adult person, what I've seen over the years is that, unfortunately, that they cycle through. That they may move, they may have a different person come in, and then you have to start that journey again. I'm optimistic that the second question you have is going to help this, and that is that sickle cell providers are a tight-knit community. And we all seem to know each other, and that's a great thing. So it's kind of like a family, and so if a patient is moving from North Carolina to New York, I know who to call. I know exactly who they need to be reaching out to. And if I don't know exactly, so for example, and this just happened recently, I had a patient moving. I knew the pediatric group there wonderfully. I wasn't sure about the adult providers because there usually are not as many adult providers to kind of lean on and be in this family. So I asked the pediatric person, I said, like, who would you lean on? Who would you send my now adult patient to? And they helped me find a provider. So I think that's where the connections are really key. I'd love for the connections to become even more formal. I'm not, of course, advocating us all being on a chat group on WhatsApp or something, but I would say that I think there are forums that we have used historically, that we post things and say, if anyone knows of a provider in this area, can you please let me know? And someone always chimes in. So I think in that way, that definitely has been helpful.
I want to ask you about transition wins, if there are any transition wins you can point to. So has there been either an idea that was implemented and made a difference at the clinic, or perhaps an anecdote or personal story of how a successful transition of care made all the difference to some particular patient or their greater family? Anything come to mind as a big transition win that you could share?
Yeah, so I'll start with kind of a general thought here, and that is that I think a part of the win for us, at least at Duke, and this is something that I push onto other sites as well, other hospital systems, is to come up with a system, try and standardize the process of moving from pediatrics to adults. So that's as simple as saying, do I have a policy? And of course, I'm not necessarily a policy guy where I have to write things down and have things put in the books, but I think it helps make things less subjective. And this goes to technically why I really champion this, is because I've seen that the transition and move from pediatrics to adults can be subjective, but the policy and the standardization to say, okay, every patient is going to have this kind of education. For our center, something that I came up with in an effort to make things simple for myself is the education I give, I put into what's called the who, what, where, and why. At age 13, 14, they need to know who they are with the disease. They need to know, what type of sickle cell they have, what is their, what are the stressors on sickle cell, dehydration, infections, etc. They need to know the medications they're on. So they need to know who they are, just the basics. When they become 15, 16, they're starting high school. Now they need to know what to do in different situations. What's a fever? What phone number would they call if they had issues? What's their pain action plan? What medications do they take down to the dosage? So, all the what, and the complications is pretty extensive. But again, I built these modules to kind of standardize what discussion happens in our clinics, not just by me, but by my learners, by my nurses. And finally, the last module is the where and why. So where are they going to go in life? Where are they going to be working? Where are they going to go to school? Where are they going to get insurance? All these who, what, where is an effort to standardize what we do to make it easier for not just me, but everyone that goes through our clinic to have this success. And I think that's led to I think that's led to a lot of wins, because I think what I'm seeing on the adult side is that more and more patients understand what's happening. They know the process. It's now not becoming a subjective decision that you should go to the adult clinic now. It's because they've met the criteria to move through that. And so I could definitely say that I've had several patients, young and old, who have expressed when they move to the adult side that it hasn't been traumatic. And to me, that's a win. I've heard many stories where the patients and families are crying because they're moving to the adult side. And this just actually happened last Wednesday. So we had our transition clinic. One of the standardized things we've done is we have a graduation ceremony on their last visit. So we come in with a diploma, we throw streamers on them, we ring a bell, we clap, we have a little speech. And so now the crying is like a happiness crying. It's not a traumatic crying. It's oh my gosh, I've not only graduated from high school, but I've graduated from pediatrics. And that accomplishment is absolutely a win for me. So I think that's something that I'm pretty proud of.
That's really beautiful. It's great to create the space where big emotion can still come forward, but now it has a different container that it can come forward in. It's a celebratory, it's a positive, it's a communal container, so there's no need for feelings of maybe shame, which can come up if it's not channeled in this kind of way. So I think that's a great idea. I'm curious, it's a little surprising to hear how non-standardized the transitional process can be. writ large. Are other centers doing similar to you? Have other places standardized their practices? I'm very curious about that.
Well, I would say that the major academic centers on pediatric side are doing a pretty good job. But the issue is that there are a lot of centers that are not major academic centers, and that there are a lot of children's hospitals that have a great program and are doing a lot of what they should be, but they haven't necessarily standardized it. And so, one common question that often comes up is, like, what got me into transition? And so I'll go ahead and just, kind of dive into that. And
Please.
I remember exactly the moment I wanted to do transition and kind of get into standardizing the approach, figure out what's the best way to get patients from peds to adults. And it's when I was a third year fellow. I'd already kind of expressed some interest in transition, but one of the patients I saw in clinic was 21. Everyone loved him. He was in pediatrics. Everyone loved him. He was a funny guy. And everyone said he's going to stay in pediatrics forever. I mean, we just love him. Why do we need to send him to adults? And I thought, okay, well, I'm a third year fellow. I can't make up the rules. That sounds interesting. That's great. And he's a good patient. So then the very next patient I had was a 16-year-old. And he was doing everything wrong, right? I mean, he's experimenting with drugs and smoking and, not wanting to come to clinic and take his medications. And the response was, yeah, he's ready to go to the adults. So we think he should probably go soon. Mm. And I just thought, why is this subjective? Why are we making this difference in when and how a patient should move from pediatrics to adults? And so, I just thought the standardization should happen, and it is the consensus. I mean, if you look at guidelines from GOT Transition, from other consensus panels, it is that we need to try and do a better job of doing this in a standardized way. So going back to your question, I think major academic centers are doing a good job, but I think there's still a long way to go. I think we still are all striving to try and continue to improve the process.
That's an interesting story. Another area of focus for you when it comes to research is on novel therapeutic options for people with sickle cell disease. Does the current treatment and investigational treatment landscape influence how you think about transitions of care? In other words, in thinking about transitions, what's true and important now that wasn't true or wasn't relevant or important, say, even 5-10 years ago?
Yeah, I think there's probably two things that come to mind here. The first is that I'm just excited that there are options that we now have. We really came in to patients' rooms and had one conversation about one medication. It was hydroxyurea. That's all we had 10 years ago. And hydroxyurea was good, but it's not enough. And inevitably patients would have complications. And so to a certain extent, patients and the discussion about treatment was very monotonous. I mean, it was very like, okay, there's hydroxyurea. I know you're on it. This is what we're trying to do. But that's all we got. And I'm excited that we finally have research effort, money being put behind sickle cell, because now I come into a transition room and I say, look, we have 4 drugs that we can talk about. We have all these different options. We have more coming down the pipeline. I love talking about what's coming, because I always want to let them know about, what's on the table as to all the things that are being researched. And so I think that goes back to having patients empower themselves to know what is out there, what they could potentially be treated with, have an understanding about their disease. And so I think that's the first aspect. And so with all these new agents, it gives me more to talk about. And when there's more to talk about, it gives me more than just how's your pain, how many hospitalizations have you had, I always, and this is just my bias, but I always spend 10 to 15 minutes at the beginning of the conversation that has nothing to do with sickle cell. I try to talk about school, the family, work, anything else I can. I try to focus at the beginning. And this is another opportunity. Okay, the next transition is, well, do you know that there's all these new things now available? So I think that's a great point. The second thing that I think is important to understand with these new agents, hydroxyurea was good because now that we use it early in life, 9 months and older, we have pushed the complications and issues down the road. And so what we have seen is that kids do great early on. And around the teenage years, they start to have some what I call speed bumps. They start to have a couple of issues here and there. Now with these new agents, patients are, I'm hopeful, going to have a little bit more of a delay. Again, and I think we're going to push things down the road a little bit further. So I think patients are going to do well. I actually think with more and more options and with the agents that we have, that younger patients will have more opportunities to be successful in school and getting to the adult world. And so now with transition and our preparing them, I think we'll have a better chance. My hope is that we'll have a better chance for them to be successful in moving to the adult world. And then again, we'll have more agents than on the adult side to continue the conversation about what to do next. So I think those are two aspects of these new agents that are being very helpful in transition.
Today's episode of Cheat Codes is brought to you by Novartis, manufacturers of Adaqvio and the Adaqvio Warrior Way program. Hey, warriors fighting sickle cell disease. You know how unpredictable and uncomfortable sickle cell pain crises can be. That's why it's so important to explore your options. One of those options is Adaqvio. What exactly is Adaqvio? Adaqvio is a treatment for people 16 years or older with sickle cell disease that could reduce how often certain pain crises happen. It is not known if Adaqvio is safe and effective in children under 16 years of age. And the Adaqvio Warrior Way program can provide you with support, including tips, tools, and resources to help you understand Adaqvio. Reducing the frequency of pain crises may be possible with Adaqvio. Talk to your doctor to see if treatment with Adaqvio is right for you, and visit Adaqvio.com to learn more. That's ADAKVEO.com. Visit Adaqvio.com today. Important safety information. What is Adaqvio? Adaqvio is a prescription medicine used in people 16 years of age and older who have sickle cell disease to help reduce how often painful crises happen. It is not known if Adaqvio is safe and effective in children under 16 years of age. What should I tell my doctor or healthcare provider before taking Adaqvio? Before receiving Adaqvio, tell your healthcare provider about all of your medical conditions, including if you are pregnant or plan to become pregnant. Adaqvio may harm your unborn baby. Are breastfeeding or plan to breastfeed? It is not known if Adaqvio passes into breast milk. You and your healthcare provider should decide the best way to feed your baby during treatment with Adaqvio. Tell your healthcare provider about all of the medicines you take, including prescription and over-the-counter medicines, vitamins, and herbal supplements. How will I receive Adaqvio? Your healthcare provider will give you Adaqvio as an infusion into your vein through an intravenous or IV line over 30 minutes. You will receive your first infusion and then a second infusion 2 weeks later. After that, you will receive an infusion every 4 weeks. Your healthcare provider may also prescribe other treatments for you to take during treatment with Adaqvio. Do not stop receiving Adaqvio unless your healthcare provider tells you to. If you miss an appointment for an infusion, call your healthcare provider as soon as possible to reschedule. What are some of the possible side effects of Adaqvio? Adaqvio may cause serious side effects, including infusion-related reactions. Infusion-related reactions may happen during or within 24 hours of receiving an infusion of Adaqvio. Your healthcare provider may slow down, temporarily stop, or completely stop your infusion with Adaqvio if you are having an infusion-related reaction. You may continue to receive Adaqvio at a slower infusion rate, and your healthcare provider may give you certain medicines before your infusion to lower your risk of getting an infusion-related reaction. Your healthcare provider should monitor you for signs and symptoms of infusion-related reactions and treat your symptoms as needed. Tell your healthcare provider right away if you get any of the following signs and symptoms of an infusion-related reaction: pain in various locations, headache, fever, chills or shivering, nausea, vomiting, diarrhea, tiredness, dizziness, sweating, hives, itching, shortness of breath, or wheezing. Adaqvio may interfere with a blood test. Tell your healthcare provider if you are receiving Adaqvio before having any blood test. Adaqvio may interfere with a laboratory test to measure your platelet counts. The most common side effects of Adaqvio include nausea, stomach area or abdominal pain or tenderness, joint pain, back pain, fever. These are not all of the possible side effects of Adaqvio. For more information, ask your healthcare provider or pharmacist. Call your doctor for medical advice about side effects. You are encouraged to report negative side effects of prescription drugs to the Food and Drug Administration. Visit fda.gov/medwatch or call 1-800-FDA-1088. General information about the safe and effective use of Adaqvio. Medicines are sometimes prescribed for purposes other than those listed in a patient information leaflet. You can ask your healthcare provider or pharmacist for more information about Adaqvio.
At the risk of opening a Pandora's box for an entire other interview, I'm curious if an adult patient was to come into your adult clinic for the first time today, hasn't been in a clinic for a number of years, isn't aware of updates on the science or options. You have a minute when they first arrive to kind of give them the overview, hit the priority that you see. What's that first minute of conversation like with this patient?
You're right. I mean, this does open up because I love kind of going into these conversations of letting patients know where we are with sickle cell. Of course, I'm going to assess, what they know. I really think a big aspect of transition, as well as just caring for patients with sickle cell, is asking questions. So I ask tons of questions. What do you know about your sickle cell? What do you know about the medications that are available? What do you know about the complications? What do you know with where you want to go? So I'm always asking questions to get an assessment, almost to the point that sometimes, and I mean, my patients know me now, but almost to the point that the patient will be kind of wonder, do I know anything? Did I read their chart? And my patients know that that's what I do, and that's my style. I'm always quizzing them to a certain extent. But for a new patient, I do that as well. I'm really just trying to get an assessment of what they know. And I think that's important because then you're able to give them the information for the gaps in knowledge that they have. And so I think that's really important to always continue to reassess. And I see this with young adults all the time. You can tell them once, you can tell them twice, you may have to tell them 3 or 4 times before it finally clicks. And so another thing that I think I really try to pride myself on is to tell stories and tell things in a digestible way. If you're talking about sickle cell polymerization, it's going to go right over their head. It's going to go over the head of even many students that you talk to, medical students. But if you say, instead of polymerization, you talk about hemoglobin as something that holds oxygen and carries it, but then once it delivers the oxygen, it turns into a magnet, right? It's positive and negative charges. And what do magnets in a bag do? They all stack on themselves, positive, negative, positive, negative. So you have to tell these stories in a way that they can understand it and then say, oh, yeah, I remember you telling me about the magnets in the bag. I get what polymerization is. And that's a very complicated topic. So I think that for sure is something that I try to do with each visit, be it 30 seconds, 60 seconds, or longer.
It's funny. Sometimes I think the royal we, the societal we, think about using stories and anecdotes like that for children or when talking to pediatric patients. But as an adult, I always want things in that kind of a... Tell me the magnet bag story again. I can't understand polymer, but tell me about the magnets. I always want... I think we sometimes overlook the need to reach adults with those kinds of tactics because some of this is just hard to digest. It's too dense, and if there's any kind of fear or trauma or anxiety associated with the disease, that's only going to make it more challenging for the average person to absorb scientific information about what's actually going on.
I love coming up with new things, and so I'm always looking for what's another cool way of telling this story. If it's a red blood cell, I can use a jelly donut analogy. If it's gene therapy, I can talk about envelopes and UPS packages being delivered.
Right.
All kinds of stuff that I've heard and things that I try to make up because you're right. I think no matter how old you are, it's really just about understanding what's happening. And if that means we need to tell a story or make it digestible, then that's what we need to do.
Another area of research focus for you is on the use of mobile technology to advance patient care for sickle cell disease, which I am very interested in. And that's a big topic in and of itself. That's another basket just waiting to be opened. But specifically in thinking about transition, what are you learning from your research into mobile technology that impacts how you think about the transition process?
My other love in life is, besides transition, is mobile apps and technology. I'm not necessarily a tech geek, but I have so many ideas that I can get the tech geeks to work on. And so one of those, and this started probably 8 years ago now, was starting to make apps for patients. And the effort was to start getting information from patients that are live, so patients can provide their symptoms, how they're feeling. They can send the information to the providers. They can see how they're doing over time with a little dashboard with their pain scores, for example, and also just record how their medications are doing. So I've used apps in lots of different ways. In transition, there have been a couple things that I've done. The one of which I think, again, goes to what I mentioned earlier is really providing the resources and education. And so, again, one of the studies that I mentioned with Dr. Asunquo, there's an app that provides education about transition. It has actually a little PowerPoint about the who, what, where, and why, and trying to get patients to understand these are the different aspects of sickle cell we want you to know. But it also has an ability to chat with an educator, a transition educator. Again, not in a medical way, but just to say, hey, how are things going? Did you know you had an appointment? Have you, been able to get all your schoolwork done? Have you had any, issues? Just in a way to have that connection. Again, going back to this concept that connection is really key. So I think apps have been great. I mean, I've been using apps for all kinds of things, and I'll definitely put a plug here that I really do think that apps and wearables and wearable devices are going to be a huge part of where we go. And I think in the mindset that transition age patients want us to be on their level, right? Now, when I call a patient to say, you missed an appointment, they don't answer. They're not going to answer. I can leave a message. They're not going to call me back. But if I text, and probably more importantly, if I text and put an emoji in there, they're going to text me back. And I think we have to get to that point where we have to realize that in this day and age, patients are communicating in a different way. And so if texting is one way to do that, if having a chat bot to allow them to communicate and work through an algorithm is the way to do that, then I think we need to change some of the modalities of providing that information to them. So that's an exciting part of the research that I'm doing.
Yeah, we have to go to their sandbox, right? We can't ask them to come play in our sandbox. We got to go to their sandbox if we want to reach them. Just a couple questions with the time that we have left. So as you know, and listeners, as you very well may know, September is National Sickle Cell Awareness Month. So my question for you, Dr. Shah, is that if you met a stranger on the street and had 30 seconds to tell them about sickle cell disease for National Sickle Cell Awareness Month, I don't know what the circumstances are that you're just bumping into this person, and because it's September, you have to tell them about this, but those are the circumstances. What would you say?
I would start by saying that most people would be unaware of the fact that we have a population of patients that's been underserved, underappreciated, and is finally, I think, getting a time where things are changing and more people should understand that they need to be part of this wave of improving the care for sickle cell. And part of that ability is to learn what sickle cell means to a patient and family, and what sickle cell means to a community. And then how can we help that process? I mean, again, with a patient population that historically has not had many options, as we kind of brought up, we now have 4 options. There's more to come. We have exciting things happening. We have money being put into this. And I say this to not only strangers, but to anyone that'll listen to me, that, if there is a time to put your time, effort into learning about a patient population and providing some extra care, it would be for sickle cell, because I just see this huge wave of good things happening, and I think the only way to do that is to continue the accelerated process of what we're doing already. I mean, I see that this last 5 years has been tremendous, and I think that it's going to continue as long as people on the street, strangers, learners, anyone that understands that this is a big deal is gonna be interested in joining the effort.
Yeah, I've so appreciated this conversation. There's a few things that my brain is kind of starting to summarize as we wrap up here. But thinking about transition, something that I've learned from this conversation, 3 C's seem to come to mind as important. Common, having that common face or that continuity of person in the care. Connection, having an actual connection, a meaningful connection with that provider is going to help me as a patient stay in communication, open up, respond back to the text even quicker. And then creativity. Hearing the story about how we create a graduation ceremony, and it's a chance to accomplish and celebrate the accomplishment of graduating through pediatric care, and gives a place for the emotions that may come up to be channeled. That's communal, another C word. But those are some of the things that are coming through to me as being really important, and I'm grateful for this conversation. Is there anything we haven't touched on that before we wrap you would like to tell the Cheat Codes audience about?
I would say that anyone who's listening and has any experience or care of patients with sickle cell disease, I would just continue to advocate to spread the knowledge. I think that that's why I'm actually so thankful that you're giving me this platform to share some of my information about transition and everything else. It's because I think every time we do something like this, every time we can reach out and spread this information, you touch another person who can then do that again. And so then you're exponentially spreading the knowledge and not just being one person in an isolated space. So I really do appreciate you being able to do this. I've listened to your podcast over the many months, and I've just been fascinated to hear the great conversations you've had. So I would say keep it up, and I'd love for the audience to keep the education as well.
Well, I'll say on behalf of Dr. Zadie and Callahan, thank you. It's all their work and their focus and their dedication. And on this side at BloodStream Media, we're just proud to support them. Thank you again for coming on this morning, Dr. Shah. Very much appreciate it, and hope to have you back on Cheat Codes in the future.
Much appreciated. Thanks. Have a great day.
You too.
Along the way, I have found many people in the sickle cell space that I have looked up to as mentors, as people who I want to model myself after, who have attributes that really allow them to stand out. And after that interview with Dr. Nirmish Shah, I feel proud that I'm able to say that he has been a mentor to me in many things. And I'm just so happy that there's individuals like him that are putting real thought into taking care of sickle cell patients in the United States.
You can tell from that interview how committed he is to sickle cell, how much thought he puts into it, all of the, programs he's putting in place to try to make things better. But I think, he's also a great guy, a friend, and, truly a mentor and a generous guy. I think in academics, a lot of times, there's a lot of great people in academics, but, a lot of times people are staking out their territory and they're competitive. And Dr. Shah is, really uniquely friendly, supportive, really all about getting good stuff done and not about credit or about, I think you wouldn't want to let him be on Cheat Codes and not let everybody know what a great guy he is.
It's true. It's true. Well, there you have it, Warriors. Just know that there's doctors like Dr. Nirmish Shah out there trying to fight the good fight with you. With that being said, you guys know, keep living well with sickle cell and share this podcast with somebody who you think could benefit from hearing about sickle cell disease, transition, and just know that there are doctors like Dr. Nirmish Shah out there.
Thanks to Patrick James Lynch, too. He's been a force behind Cheat Codes, so I'm glad got a chance to hear him in person, but also looking forward to getting back into doing the interviews ourselves soon, Dr. Z.
Same. With that being said, follow me at Dr. Z Sickle Cell.
And me at Imagineer.
We'll catch you at the next episode. Peace.